Good morning, everybody. Today I shall share laparoscopic assisted management of a baby with a complex anorectal malformation and perforated congenital pouch colon. Congenital pouch colon is a rare anorectal malformation. The baby has got absent anal canal and colon is replaced with a cystic pouch called pouch colon or football colon. There are 5 types of congenital pouch colon and variable length of the colon is affected. In type 4 pouch colon, the ascending, transverse and descending colon is normal and the rectosigmoid colon is affected only. A full-term baby presented to us with the absent anal canal, distended abdomen, meconium staining of urine and showing signs of peritonitis due to bowel perforation. A cross-table babygram showed that there was more than 4 cm gap between the rectal pouch and the anal dimple. Baby was resuscitated and emergency laparotomy was performed that suggested a perforated necrotic pouch colon with meconium peritonitis. The question was how to manage this case. So we performed a colostomy and distal pouch was closed as a Hartmann's procedure. The baby had an uneventful recovery after surgery and was discharged home after a few days with a plan for definitive surgery at the age of 4 to 6 months. MRI after 3 months showed a normal spine and there was a huge big dilatation of the pouch colon that was closed as a Hartmann's procedure. So this was a challenging case because we have to create a new anal canal with the good sphincter control. We have to excise the pouch colon, which has got a fistula with the urinary system, without damaging the pelvis structure and to repair the rectourethral fistula. And above all, the problem was to perform these procedures in a small baby laparoscopically who had previous laparotomy and peritonitis. Laparoscopic surgery was planned at the age of 6 months. First, anal sphincter was identified using muscle stimulators. Then urethrocystoscopy was performed for the identification of the rectourinary fistula. Later, a laparoscopy was performed to excise the pouch colon and repair the rectourethral fistula. After excision of the pouch colon, a coloanal anastomosis was performed. The first step was to identify muscle sphincters. Good muscles contractions were noted and muscles were identified and the center was marked. Then patient had cystoscopy and after cystoscopy we were able to find a fistula at the level of prostatic urethra. It was a wide fistula. After the identification of the fistula, we checked rest of the bladder and that was normal. Then laparoscopy was performed and we were able to see the large pouch colon which was full of infected material that was aspirated and using monopolar diathermy the pouch colon was carefully dissected from the surrounding structure that was later assisted with a ligashore device. It was possible to preserve all the structures and keeping very close to the colon itself and therefore no damage was done to any surrounding structures. At the level of the fistula, further dissection was done using sharp diathermy to avoid thermal injury to the surrounding tissue. The fistula was then closed, ligature. The colostomy was then undone and then the anal incision was made at the level of the identified sphincters and it was gradually dilated with a Hager's dilator. The pouch colon was removed and the normal colon was pulled through the newly constructed anal area. The cavity was thoroughly washed with normal saline to remove any infected material. Part of the colon did not look healthy, therefore that was excised and a coloanal anastomosis was performed using interrupted 5-0 Vicryl sutures. As you may notice that the pouch colon was significantly thickened due to recurrent infections and obstruction. The baby had an uneventful post-operative course, started passing stools after a few days and was orally allowed after 6 days. EUA and anal dilatation was performed and baby was discharged home after 2 weeks. The baby was examined under anesthesia after 8 weeks. Anal canal was adequate and or allowing size 12 Hager's dilator. Anal sphincters were also nicely placed around the sphincter. The baby later on continued to pass stools normally. However, he developed a perianal abscess that needed management. Currently, the baby is fine, is off the anal dilatation, and is taking normal feeds and passing stools normally. So we can conclude that complex anorectal malformations can be managed by minimally invasive surgery. And in type 4 pouch colon, laparoscopic excision of the pouch colon with coloanal anastomosis can give excellent outcome. Thanks for watching this presentation. I shall be glad to answer any queries on my email given below.